Hello and welcome to the final night of the Alamo Breast Cancer Foundation's Hot Topics Mentor Sessions. I'm Carole Baas, the moderator for this evening. I'm sorry we're starting late. Dr. Susan Love is going to be joining us as well. She will be joining us a bit later. And because we're starting late, we'll go ahead and run a little bit past our scheduled time. So it's 5:35 Central Time now, so we'll run till 7 o'clock or so. So I'm a member of the Alamo Breast Cancer Foundation's Advocacy Education Committee. I'm also a breast cancer survivor. I was diagnosed in 2004, originally with DCIS, and then this summer I was diagnosed with early stage invasive ductal carcinoma. So tonight we're going to be discussing information that was presented at the San Antonio Breast Cancer Symposium, which concludes this evening. So this session is going to begin with each mentor providing an overview of a specific topic or sessions. So for everyone there in person or online, make sure you post your comments and questions during the talks. They'll be answered after all of the mentors speak. So before I introduce our mentors for the evening, all of us at Alamo would like to thank them for giving so generously of their time and their knowledge. We truly appreciate them, as well as I know all of our viewers do, for your interest in expanding our knowledge of breast cancer and for your continued support of the Alamo Breast Cancer Foundation and all of our advocate programming here at the San Antonio Breast Cancer Symposium. So this evening, we're pleased to have three truly distinguished mentors: Dr. Susan Love, who hasn't joined us yet, Dr. Debu Tripathy, and Dr. Doug Yee. So a brief bit about each of our mentors. Dr. Love has dedicated her professional life to ending breast cancer. As the founder and chief visionary officer of the Dr. Susan Love Foundation for Breast Cancer Research, she oversees an active research program that's centered on finding breast cancer causes and prevention. So Dr. Love trained as a surgeon, and then she was on the front lines of breast cancer advocacy in the early 1900s as one of the founders of breast cancer advocacy. She continues her work by serving on the boards of NBCC and the Young Survival Coalition. You may also know her by her books: Dr. Susan Love's Breast Book, Dr. Susan Love's Menopause and Hormone Book, and Live a Little. Her recent projects include the Love Research Army, which partners people and scientists to accelerate breast cancer research. So we're also privileged to have Dr. Debu Tripathy with us tonight. He's a professor of medicine and chair of the Department of Breast Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. His clinical research focuses on the evaluation and development of new therapies in breast cancer, specifically growth factor receptor pathway targeting and biomarkers that predict sensitivity and resistance. He's also editor-in-chief of Cure magazine, which I hope you all read. I find it a wonderful resource. And previously he served as president of the American Society of Breast Disease and the Society of Integrative Oncology. And finally, last but not least, Dr. Yee is a medical oncologist with a specialty in breast cancer. His laboratory has been interested in the regulation of cancer cells by insulin-like growth factors, known as IGFs, and insulin. So he also maintains an active clinical practice in the medical management of breast cancer. As part of clinical care, he serves as the site principal investigator on several clinical trials that employ experimental therapies that are targeted against the IGF receptor and the PI3 kinase pathway. He's the director of the Masonic Cancer Center at the University of Minnesota. So with that, we can go ahead and get started with the discussion part of our evening. So Dr. Tripathy, we're going to have you go first. So tell us what you've learned at SABCS this year and what we should get as takeaways.
Well, thank you, Carole. It's really a pleasure to be here, and I want to thank all the organizers for setting this up for many years. I think it's a wonderful venue from communication, and believe me, I've learned a lot from the questions that I have gotten and some of the responses and comments as well. I wanted to spend a little bit of time talking about hormone receptor positive breast cancers. And I've taken my turn over my career, which started really with HER2/neu. My project as a fellow was to turn the HER2/neu gene off. And in so trying to do that, had to work with antibodies, including one of them that turned out to be Herceptin, and led to one of our first major targeted therapies in breast cancer. And since that time, I've stayed interested in the cell, how the cell signals, an area that Doug Yee is also working in. But cell signaling is such a varied thing. There's obviously normal signaling that goes on, and then there's abnormal signaling that can actually drive breast cancer and other cancers. In the case of breast cancer, signaling through the estrogen receptor is a big component of about 2/3 or even more of all the breast cancers that overexpress the estrogen receptor, which serves as a normal growth factor for breasts and other tissue as well. But because cancer is survival of the fittest, and mutations and other genetic changes that can happen over place allows for selection of the fittest, one of the common paths to cancer is through estrogen receptor signaling. And over the years, we've learned to target that by blocking the estrogen interaction of estrogen with the estrogen receptor as far back as over 100 years ago, when oophorectomies were done before we even knew what estrogen was. We now move into the modern era, and we've learned that targeting estrogen receptor with hormonal therapies can be augmented, because we've spent a lot of time and invested time in understanding why cells become resistant to hormone therapy. One of them is through the activation of growth factor receptor pathways. And drugs like everolimus, known as Afinitor, were one of the first efforts to block these pathways and augment the effects of hormonal therapy. More recently, the cell cycle itself, which is a very highly choreographed set of biochemical reactions that leads to the division of normal cells, can be co-opted by mutations that augment and exaggerate the cell cycle. It's one of the areas where we see a lot of mutations. And just about all growth signals have to go through the cell cycle apparatus to get the cell to go from its resting phase, which is the normal situation for most of the cells in our body, into the active growth phase. And estrogen receptor and other growth factor receptors signal through the cell cycle. So it's an obvious target for cancer for many reasons. And it's been targeted for years, but it was too toxic because we were targeting it non-selectively. And in the last decade or so, there have been very selective inhibitors of different cyclin-dependent kinases that operate throughout the cell cycle. The CDK cell cycle-dependent kinase 4 and 6 are the ones that have been now entered initially into clinical trials and now are a part of standard therapy. So now just about all patients with advanced hormone receptor positive cancers are potentially candidates for being treated with this drug, which has doubled progression-free survival and improved survival as well. But it's not curative. And so there's much more we need to learn about the CDK inhibitors and other ways that we're targeting the estrogen receptor. And so at this meeting, there has been some further insights into what might predict who responds and who doesn't respond to these drugs. We've learned that certain expression profiles that are common in different subsets of cancers that are now called luminal A, luminal B, HER2 enriched, and basal, those are the major subtypes, and they roughly correspond to the receptor subtypes like estrogen receptor positive, progesterone receptor positive, and HER2 positive or negative. And we learned more about that at San Antonio in terms of from the patients enrolled on these trials, how these different subsets affect responses. We've learned, for example, that the very small number of these cancers that are of the basal subtype, which biologically is more like triple negative, even though they make the estrogen receptor, don't respond to these drugs. We also have learned that the mechanisms of resistance involve certain genes that can be targeted. One of the things we're working on is a pathway called the STAT3 pathway, and we presented a poster at San Antonio that looks at targeting that particular pathway. And then I'll just end by saying that this field continues to evolve. We saw the first presentation of a whole new generation of drugs that block the estrogen receptor called selective estrogen receptor downregulators. There have been now several clinical trials that have explored several of these new drugs in early phases. And we saw the results of the first phase 3 randomized trial comparing standard anti-estrogen therapies, in this case, fulvestrant or Faslodex, a commonly used second-line endocrine therapy, to the SERD elacestrant. And this trial, known as the Emerald trial, did show it to be more favorable than fulvestrant. So this now introduces a whole nother set of hormonal therapies that we can combine with other biological therapies. So we're awaiting the results of those trials. We also know that one of the mutations that cancer cells can acquire are mutations in the estrogen receptor itself that make the estrogen receptor active even without estrogen around. And it turns out that this drug, elacestrant, seems to be even more effective against cancer cells that harbor this mutation. So this is a taste of what we have to come, incremental steps forward. We're hoping that these incremental steps will turn into major steps that can essentially prolong remissions for such a long time that patients' lives are extended to what they normally would have been if they didn't even get breast cancer. And in the case of early stage breast cancer, that the cure rate can be improved. So I do think that we're on the right track and that progress is accelerating in this area as many others, and you will hear about that over the course of today. So I will stop there with that one segment of biology and clinical breast cancer that I think is very important. Thanks.
So thanks, Dr. Tripathy. So Dr. Yee, do you want to give us your
Sure. I also appreciate being here, although I do not appreciate not seeing you, the audience. I think this is probably the second time, because last year it was virtual. Second time we did this virtually, but I really like meeting with the group and seeing people and getting your questions. So I'm looking forward to that part. So I'll try to be short. I've also never done this at the end of the symposium. I always seem to always do it the first day. So my brain is pretty full. I don't know about you guys, but there's been a lot to think about. What I thought I'd talk about or say a few words about this morning that I heard this morning was about race and ethnicity and outcomes, because I think it's a critically important area that we as a community need to have a better handle on. So I'm going to start with what the discussant said. For those of you that were at that talk, Lisa Newman gave an overview of her view of the world. And the one thing that she made very clear, and I think is important for us to understand, that the term race and ethnicity in many ways are artificial constructs. Well, my colleagues who do, heavy duty genome like to talk about ancestry. They don't like to talk about race and ethnicity because in many ways that's not a particularly meaningful term. If you heard Dr. Olapati's talk, she also brought out the discussion about how do you define your ethnic group. As somebody whose parents came from China, I also know that we as Asian Americans get lumped into this big gigantic group that includes South Asians and many different groups that don't necessarily reflect genomic background. So Dr. Newman did a very nice job of demonstrating how there are different genomic markers depending on where people came from in Africa. So first off, I think that's important to keep that in mind as a construct. But beyond that, what the two abstracts I wanted to talk about, one of them was from Memorial Sloan Kettering. Dr. Barrio presented a very interesting presentation on looking at the impact of race and ethnicity on severity of the lymphedema after axillary lymph node dissection. Oh, good, and Dr. Love is coming on too. So I hope she doesn't want to talk about the same things, but she can talk more about lymph nodes later. But I just wanted to point out this part was that first they used sort of a sophisticated machine. If you saw the presentation, women would stick their arm into the machine. It would do a very good job of measuring arm swelling. So it wasn't sort of self-reported lymphedema. And at the same time, what they showed was there are a couple factors that were associated with worse lymphedema, and one of them was self-identifying as Black. That was not entirely clear why that should be. The speaker brought up some potential biological consequences. Maybe the inflammatory response among Black women was different than those among Caucasian women. Maybe there were different responses to therapy, but it really was not entirely clear. In the chat, I actually asked a question, and I'll just go out on a limb. I will bet that this would be the issue. Was there equal access to post-surgical lymphedema therapists between Black and white women? I was a little surprised by the speaker's answer, saying that was not a built-in part of their program. You know, not every woman who had a lymph node dissection, in my view, should get referred to a lymphedema specialist. That was not apparently part of the program, and I would put reasonable money on the fact that there's a health disparity there about Black women getting referred into the appropriate specialist. Although that, and I'm not saying that's a flaw of Memorial Sloan Kettering. I'm saying that's all of us don't necessarily offer the same post-surgical therapy to Black and white women equally. So the other part that went back to back with this was a result from iSpy, presented by a really up-and-coming medical student, Ms. Kyle Awazi. So in iSpy, and my disclaimer here is I'm involved with iSpy as well. It's a neoadjuvant clinical trial. I should backstep for a second. And one of the observations from the Memorial Sloan Kettering group is that women who got neoadjuvant therapy actually had worse lymphedema too. So it's not entirely clear why that is, or if that's a consistent observation amongst groups. You know, there's an argument that, well, if you kill tumor in the lymph node or in the breast, you'll send out more inflammatory signals, and that could cause lymphedema. It needs to be studied and understood. But going into that, the iSpy 2 clinical trials, the primary endpoint is pathological complete response. I think we've heard throughout the conference and at other points that African-American women have worse outcomes for similar stages of disease compared to white women. What we found in iSpy was that Black women and Caucasian women and the Asian women, which are not as highly represented, had equal outcomes. And their outcomes were independent of ancestry, race, or ethnicity. Now, the interesting observation was that women who had hormone receptor positive tumors, their outcome was worse if you were a Black woman as opposed to a Caucasian woman. So how do we interpret that? And again, I will give you my overinterpretation without any data, really. I think when women are on a clinical trial, everybody pretty well gets treated the same. In other words, you will follow the same protocol, and so race, ethnicity, ancestry don't actually play a role in one's outcome. However, afterwards, and this is where the hormone therapy part is important. So the patients who did the worst that were Black were hormone receptor positive, HER2 negative. There, it's critical that long-term follow-up and compliance, as well as administration of endocrine therapy for a longer period of time, is important for us to employ. So there may be also health disparities around giving appropriate endocrine therapy after you finish your protocol therapy. In other words, iSpy did a pretty good job of making sure there was equity amongst therapies for all women who, regardless of race or ancestry. But in contrast, I'm not sure, and this is something we need to go back and look at now that the data were presented, that we do equally good post follow-up care. So I would put these two abstracts together in kind of the same bucket. Are we making sure that Black women, after their therapy, get the same kind of care as the white women or Asian women? And that's a health disparity issue that we need to address. So there's a couple things I wanted to talk about. Just as a point of information, the other thing I do with my colleague Ruben Harris is work on APOBEC mutagenesis. There were a couple of presentations on the APOBEC mutagenesis today, but I'm not going to talk about that unless there are questions that come up in the Q&A session. I'll turn it over to Dr. Love.
Well, I'm not actually supposed to be on this. I logged in to see what you guys were saying. So, but and I just happened to show up as, I guess, as a little in this little square. So who knows? I do think that lymphedema is a major problem, and the problem too is people's anatomy is different. So you may have, and we have to do a better job at studying the anatomy. We've been working on the anatomy of the breast duct, and it's interesting how it's completely different than what I learned and completely different than what we do in surgery. And I think that's probably true about lymph nodes and how they're distributed as well. And so we probably take too much tissue out because we don't know the anatomy, and that's why we see so much lymphedema. But it needs work. It certainly needs study. And with that, since I'm not really supposed to be here, I will block myself off.
Well, we did introduce you, Dr. Love. So if there's
good.
something,
Okay.
if there's something that you want to talk about,
well, I think not necessarily. We've been working on some different, basically on the anatomy of the ducts in the breast, and it's very interesting because the breast doesn't look like a pizza or a pie. You know, it actually, they're in two layers, and there's one group that goes directly back from the nipple to the chest wall, and then a second group that's grouped around it and draped around it. So the way we were taught to do surgery in quadrants or even slices, it is certainly not getting the whole ductal system. And we really have to rethink about that. And I think maybe I've been thinking recently a lot about what about you doing a liquid biopsy through the nipple. We used to call it ductal lavage, but you can wash out one duct and then look at the cells, and that might be an interesting way. And then do something to map it, so then you know where to go, or squirt the treatment down the duct and see what happens. So I think what we've been doing, and Debu remembers for a long time, and then we stop. It may be time to come back again. And it may be that if you just last long enough, your ideas reemerge. So that's what we're working on, though, here. And I think you'll hear some more about it maybe by next year. And I'm gonna stop there.
All right, thank you. So I guess we'll go ahead and we'll start with questions that have popped up in the chat. So Dr. Tripathy, there's two that are directed towards you. Can you see those?
Right. So one of the questions is about elacestrant, which is the selective estrogen receptor downregulator that I was discussing earlier. The Emerald trial was interesting, and it was a well-designed trial because I think it reflects real life. It was basically for patients who had advanced breast cancer that was hormone receptor positive, and they had already progressed after either one or two hormonal therapies. So it could be any of the hormonal therapies that we commonly use, tamoxifen being one, aromatase inhibitors like letrozole or anastrozole being the other, and fulvestrant, which is the injectable drug, also known as Faslodex. So patients could have had either one or two and had progression, and then they were randomized to get either whatever their doctor thought was best in terms of one of the other hormonal therapies that they had not yet seen, or they could receive elacestrant. So they were randomly assigned to those options. And the overall analysis was really focused on half the patients that got elacestrant and then half the patients that got one of the approved endocrine therapies of choice. And the winner was clearly the elacestrant group by about 40% fewer recurrence events. So it was a strong positive study. The question was, what about people that had fulvestrant already? And that was about 40% of the patients. And when they looked at that group in isolation, it also did better than the elacestrant. So it looks like elacestrant is a drug that will work for patients who are resistant to endocrine therapy or who have received it and then progressed. And the the next set of studies really is going to be, can elacestrant be combined with some of the biological drugs that we're using, like CDK inhibitors and the so-called mTOR inhibitor known as Afinitor, or everolimus is the generic name. And then the other question is, what about patients who have received chemotherapy? Can they respond to endocrine therapies? And the answer generally is yes. We used to treat almost all patients with metastatic breast cancer with chemotherapy back in the old days when I started my fellowship. And that has shifted, thankfully, to using hormonal therapy, because it turns out it's just as effective, maybe even more effective, and generally has fewer side effects, although not always, you know, and hormonal therapies can have a lot of difficult side effects too, so I don't want to belittle that. But now, really, most patients are candidates for using hormonal therapy, and nowadays, coupled with biological therapies like the CDK inhibitors. However, there are some patients who have very rapidly progressing cancers that we feel chemotherapy might be the best option for them. And sometimes when those patients have an initial response, rather than just keeping them on chemotherapy, we'll then do what's called maintenance therapy with hormonal therapy, and that is sometimes successful. So patients who have received chemotherapy can respond to hormonal therapies, but our experience with elacestrant is very limited. In the early phase 1 and phase 2 trials, there were some patients that received it, and some did respond, but we haven't treated enough patients to be able to calculate what the average response will be across a large population yet. And those studies are planned, so we just don't know as much about that. So I will stop there. Although I do have one comment for Sue, because you know she's been doing some really pioneering work about the breast duct, and I did want to get her insights as to whether, in terms of treatments through the breast duct, there's one trial that I'm familiar with Herceptin for HER2 positive ductal carcinoma in situ, and it was a smallish trial. But I'm just wondering technically how feasible that is, and what have you learned, and also what have you learned from the analytics? I think there's some cellular work that you've done, and maybe even some single cell RNA sequencing that you or others have done, and so I'm curious to get an update on that.
Well, it's actually not hard to squirt the chemo down the ducts. It depends on the size of the opening of the ducts. And so a woman who's been breastfeeding a lot or has had a lot of kids, it's much easier than somebody who maybe is nulliparous and postmenopausal. But it's still not that hard. And you can cannulate it with a angiocath or a very small catheter, and then squirt in a little bit of contrast you can use in order to see where it is if you want, or use ultrasound. We've been using ultrasound a lot, and we have really good new map of the breast ducts from that. And so that would be the way. Now the question is, we've always assumed it's only one duct that's bad. And I think we don't really know that. And now that we have this map, we'll be able to sample different ducts and compare them and see whether we're talking about something that's all the same, or whether we really have one duct we have to deal with, which would be much easier. So the map is going to really, the ability to map with ultrasound is going to really change, I think. It's been the barrier that I've been looking to break for a long time. And I think it's going to open up a lot of, it's going to teach us a lot about the breast and how things are distributed. And then that will help us, give us access and allow us to treat things better.
Thanks.
Are there any questions at the live audience? Live and, oh, you don't have to turn off your camera. Yeah. The live.
Can I answer a question that came up in the box?
Of course.
About
please.
lower doses of treatment medications that generate similar efficacy. So, you know, when you think, so many of us, and this group of mentors is modestly old. So most of the drug development had been built around finding toxicity. So the idea that you would get a drug to a certain level and you'd back off on that level, if it was regular chemotherapy, that's what you would give. But at the same time, for all of us who work in biological effects of the drugs, what you really want to know is when the drug engages a target and when is that target downregulated? I think the best case example of this is tamoxifen. You know, tamoxifen engages the target, engages the estrogen receptor. Where did the dosing of 20 milligrams per daily come from? Well, it came from studies that said that 60 was too much. But as you know, our European colleagues have backed that dosing down to 10 and 5 and have roughly biologically equivalent effects. I will say in my own personal world, there was a monoclonal antibody against the IGF-1 receptor. It was something that I had been interested in for a long time. The company that was developing that drug, I'll leave it unnamed, did a dose finding study, and they also did concurrent biomarkers to see when the receptor was engaged. So they actually found out it was engaged at a very low dose of this antibody, but nonetheless, the phase 2 dose that they went with was basically 10 times higher. And for no good reason other than they said, well, they wanted to saturate the receptor. Ultimately, I think it led to more toxicity, might have led to drug failure, who knows. But either way, whoever, Christine Hauser, who asked that question, that's a really excellent question, especially as we get to start to combine things. If you listen to some of the talk today, they talked about combining different strategies to hit DNA damage repair response, like PARP inhibitors and ATM inhibitors or WEE1 inhibitor, whatever you want. If you go with high doses, you're going to have a lot of toxicity. You may be able to go lower, engage the target, and have equally synergistic effects. But to be quite straightforward, those are hard trials to do. To do 2 drugs and do the appropriate dose finding for 2 drugs, much less 3 or 4 drugs. And just one last thing, we did a trial within the context of I-SPY where we thought we'd put drugs together because it would be easy in HER2-positive breast cancer. So the drugs we put together were trastuzumab, Herceptin, pertuzumab, Perjeta, Taxol, and tucatinib, the new tyrosine kinase inhibitor. And we sort of, I don't want to say we didn't think about it. We did think about it, but we learned that that was a combination. It was extraordinarily toxic to the liver. My colleague, Dr. Potter, presented that at a poster discussion session, and we just had to give up on that combination. But I think you're right. We're not doing those studies as well as we could.
So I wanted to ask Dr. Love, you were talking about creating the ductal maps. Before I was diagnosed with breast cancer, I breastfed my children, and I got very interested in, you know, how milk is created and how does it flow. And so I know the breastfeeding community has also been interested in and has been studying the ductal system. Do you partner at all in terms of the cancer world and the breastfeeding world with helping to create these ductal maps?
We did several years ago, and then we didn't really, it was with the visual ways we had to visualize it and the different techniques, it got too confusing. So we could see where the ducts were, but they were interacting and they were, you know, one was folding into the other, and it was difficult to follow them and track them. So you could do one duct at a time, but you couldn't really get a very good picture of all of them. And most of the pictures you'll see in the literature make the ducts look like a pizza, you know, with wedges, and that each wedge is a ductal system. And it really isn't like that. And so now having this new way, and there's a company in San Francisco that's doing this, a new way of doing ultrasound called QT ultrasound. And so I had a conversation with them about how difficult this was to do. And next thing you know, they popped up with a way to do it. So if you go to their website, you can see a very nice picture of the ducts. And we're working with them now to try to see how consistent is it. Does it, you know, is it different postmenopausal than premenopausal? And all of that. So maybe by next year, or certainly the year after, we'll have really a lot of information about the duct distribution, but it's not anything like any of us were taught.
Okay, thank you. Dr. Yee, I wanted to ask you, you were talking about diversity issues and healthcare equity. I guess I'll put you on the spot here because you talked about how we need to address health disparities. How are you doing that at your cancer center?
Yeah, so that's actually a very good question. I think you mentioned in my introduction, I'm also the center director at our place. I think that for us to direct, to correct issues around diversity and equity, you have to look at the entire operation, all the way from the staff, the nurses in the clinic, the medical students, the trainees, the faculty, the leadership. So I think, at least at our institution, we've appointed a director of diversity, equity, and inclusion. She is a gynecologist. Minnesota has a very high incidence or immigrants from East Africa, from Somalia. So her particular focus has been on trying to do cervical cancer screening in newly arrived Somalis. So one, it requires top to bottom appropriate cultural approaches to the issue, all the way from, what is cancer, to not having you do gynecologic exams, and how do you do a HPV screen or pap smear in women who have never routinely had gynecologic care. So it goes all the way from top to bottom. And while you're asking this question, and I will give you my opinion, and I guess this is going to be recorded so people can quote me. I think one of the reasons we didn't make much progress, or haven't made as much progress, in triple negative breast cancer is because we haven't included women with a higher incidence of triple negative breast cancer. So Black women, when you look in clinical trials, they're not highly accrued. We've done pretty well in estrogen receptor positive breast cancers because most of the clinical trials enrolled women of European descent, and that's the high frequency cancer there. So I'm not going to deny that we've made incredible advances in ER positive breast cancer, but in many ways, the lack of progress in triple negative breast cancer, I would argue, is a lack of inclusion of the appropriate populations. And again, it takes the whole institution to pitch in on this. It's not driven by a single person or even a single specialty.
All right, thank you. Let's see.
Somebody asked about ovarian functional suppression. Debu, you want to take OFS?
Yes, I can address that. Ovarian suppression is a form of hormonal therapy. As I had mentioned earlier, estrogen is a normal growth factor for normal breast tissue as well as other tissues. And in breast cancers, about 70% of them actually overexpress the estrogen receptor, which allows them to use estrogen to really fuel their growth in a more pathological way. And so treating that interaction between estrogen and estrogen receptor really has been the focus of hormonal therapy. Most of the hormonal therapies we use today work that way. Tamoxifen, for example, blocks the effect. Aromatase inhibitors work by simply lowering the amount of estrogen, as does ovarian suppression. So in premenopausal patients, that was really the first group of patients in which Sir George Beatson is the name of the Scottish surgeon who published a paper in The Lancet in 1896, where he removed the ovaries of patients that had, and in those days, people with breast cancer had advanced breast cancer for the most part. And really the observation he made is that there's a connection between the ovaries and the breast. And that was known, from ovulation, the breast changes. And it was an obvious connection to make, even without knowing the underlying biology. And of course, many years later, the estrogen and estrogen receptors were discovered and characterized. And then synthetic drugs were developed that block the estrogen and estrogen receptor interaction. But in premenopausal patients, suppression of the ovaries remained and still remains an important tool. In fact, some of the initial randomized studies for breast cancer were oophorectomy trials in all patients before we even were testing for estrogen receptor. And now in the more modern era, the ovarian suppression sort of fell out of favor, but it was still a useful tool. And only recently were studies done where patients receiving early stage breast cancer, in addition to hormonal therapy, had suppression of the ovaries for 5 years. Now that we had medical drugs that are monthly injections that can be given to suppress the ovaries, and people didn't have to necessarily have an ovarectomy, because we certainly don't want to suppress people's ovaries for very long. We've known for many years that women that happen to have their ovaries removed because of infectious disease, which used to be very common decades ago, or for other reasons, actually have a decreased life expectancy and may encounter things like osteoporosis and cardiovascular disease at an earlier age. But using medical ovarectomy, one can suppress for 5 years. And so 2 trials were done, the text and soft trials, in premenopausal patients. And these are patients who, if they got chemotherapy, they were still having regular periods after completing chemotherapy, or they didn't receive chemotherapy at all. And they were randomized to have their ovaries suppressed for 5 years versus not. And on top of regular endocrine therapy, either tamoxifen, or there was one of the studies that actually compared tamoxifen to aromatase inhibitor therapy. And an update of those trials was presented at San Antonio and showed and confirmed very clearly that there is an impact anywhere from 5 to 10%, depending on the risk features, such as positive nodes and things like that. And that the patients that were on aromatase inhibitors actually had a better long-term outcome. So that now has become the standard of care for patients with higher risk breast cancers. For people with lower risk breast cancers, there is added toxicity, as you might imagine, from suppressing the ovaries. And so for people, for example, with node-negative breast cancers whose features are such that they don't even need chemotherapy, that might be a group of patients where tamoxifen alone would be adequate. But we do think that there is now really good proof that suppressing the ovaries adds more. It adds more in the way of side effects too, and those are not to be minimized because, for some people on hormonal therapy, it's minor and it's not a problem, but for some people, it is really debilitating. And there was really an interesting study that was published earlier this year looking at patient-related outcomes in a group of patients who either received chemotherapy or received chemotherapy followed by hormonal therapy or received hormonal therapy alone. And interestingly, guess who had the best long-term side effect profile, not just looking at the time they may have been on chemo, but for looking for 5 years. That group was the group that did not get hormonal therapy, including the ones that got chemotherapy. So when you look over the course of time, the quality of life is actually better when you're not on hormonal therapy, even if you have to get 6 months of chemotherapy, when you're looking at the big picture. Because some patients now are getting extended hormonal therapy, which does incrementally improve things, especially in higher risk breast cancers. So I don't want to minimize the impacts of that. And there is an area where we need to do much more research. However, when you simply look at the question of lowering the risk of recurrences and lowering mortality, which of course is a very important aspect that has to be balanced against side effects, the tech soft trial update presented at San Antonio clearly confirms that is a better option. And what we'd like to do, of course, is to be able to mimic that effect with other ways that don't cause the same amount of side effects, but we haven't gotten there yet.
So I want to get Dr. Love's take on this because she literally wrote the book on menopause and hormones. And as someone, I myself have been on hormonal therapy, and it's not always a walk in the park. So anyway, Dr. Love, weigh in.
Well, I think that's true. It's not always, and I think it has a lot more side effects than we've given credit for, particularly since when the medical profession was almost all men. As we eased out of that and we had more women involved, I think we started to recognize that these hormones really do have significant side effects that may or may not be worth it. And I think the woman has to be the decider of that. She has to decide whether she can live with it. And sometimes the benefit is marginal, but because we have a drug and we know it works, we give it anyway. And I'm not sure that's always worth it in terms of the long-term effects.
Okay, we've had a couple of questions come in about the cost of treatments and these new drugs that are coming out. Any thoughts on that?
Sure, I can take a crack at it, and I'm sure Doug will weigh in too. He's been very involved in new drug development, but you know, the equation right now is that drug companies can essentially call the shots on how they price their drugs. There's no regulation on that. In England, in contrast, the National Health Insurance, NHS of UK, which most people employ, a few people are out of it and pay their own way, but most people actually count on the National Health Service in England. They will not cover the cost of a drug that is beyond what a formula that they use, which is based on quality adjusted life years saved. So not only the quality of life, but the number of years that a drug saves it cannot exceed a certain threshold. It used to be 50,000 pounds a year. Now I think it's up to 80,000 pounds a year. But that's all they will cover. So the drug companies price their drugs so that they meet that. And in the United States, that is not the rule. In fact, it's the other way around. The drug companies are protected by a law that states that Medicare, which is the biggest consumer of drugs and actually has bargaining power, like any large group does, cannot bargain with drug companies. They are forbidden from doing that. So right now, drug companies recoup as much as they can for a popular drug. And their budget, about a third of their budget is for marketing the drug, which, you know, everything is marketed in this country. It's not necessarily an evil thing, but, you know, when people cannot afford drugs, then that does become a problem. So, you know, I think that we need to really take action at a community, at a grassroots level, to make sure that drug companies are rewarded for their inventions, just like any company should be, but that there are some reasonable limits so that drugs are just not out of reach. And it affects us all, even if we have good insurance and it covers the cost of our drugs, it still drives the cost of healthcare up. And the proportion of healthcare that is represented by drugs has been creeping up and up and up. Because we now have these very sophisticated CAR T-cell drugs and things of that nature that are extraordinarily expensive, that can cost $500,000 to $1 million for a course of treatment. So while we certainly want our pharmaceutical industry to be vibrant and robust and innovative, I think we have to strike a balance with disparities that Doug Yee spoke about, where some people just don't have access to these drugs. And it's, again, this is a societal issue. I personally believe that we can have these controls in place and still have the kinds of advances we want to have in pharmacology and all these great new drugs that are coming in. We do need that, but we have to strike a balance. That's my soapbox.
I'd also add to that soapbox. So I agree with Debu that drug companies have to be part of the partnership, because academic centers can't do this, make drugs and do the clinical trials. But having said that, almost all the discoveries come from fundamental research that came out of academic centers and was funded by your tax dollar through the NIH or the NCI. So if you think about estrogen receptor, well, drug companies didn't clone the estrogen receptor. HER2 was not discovered by the drug companies, but nonetheless, it's critical that the NIH NCI continue to be the discovery engine. But at the same time, I guess I'd argue that, you know, there should be a little bit of pass-through back to the NCI or the NIH because we're the discovery engine. And then, you know, I couldn't agree more with Debu about Medicare bargaining. I read a book once about how Walmart succeeded, and Walmart succeeds because they say, you know, I'm going to buy 10 million lawn chairs this year. So you guys that make lawn chairs, give me your best price and we'll go with that. So if you think about it, and if there are any drug company people on, I'm not criticizing you, but we never do that. If we said, well, there are 3 aromatase inhibitors that are all about the same, So give me your best price, and that's the one we'll go with. You can have access to the other one. You just might have to pay a little bit more. But as it was said, and again, I'm probably going to get attacked, but the pharmaceutical company lobby has very strictly put in place that they don't want that. They don't want to negotiate drug prices with the federal government, which seems nuts to me because the federal government's paying for it, and they actually pay for the development of the fundamental discovery of those drugs. Can I just make one comment about the cost of clinical trials? It is true, costs of clinical trials are getting higher and higher because the data asked to be collected is getting more complicated too. But again, there's real ways to do cost savings. Prior to the time when there was electronic medical records, you would get a piece of paper, somebody write it down on another piece of paper, and then somebody write it down on another piece of paper and give that to the drug company, and that's how you would gather your data. Now that there's a single source of entry of almost all the data, we need to harmonize our data collection systems. And if we did that, I will bet you that would cut out huge amounts of cost to do a clinical trial. And beyond that, I think even the concept of real world data, and you as advocates need to advocate for this too, is that you can say that my data are available for research because I think I want to commit to the greater good.
All right, thank you. We had some questions right at the very beginning that dealt with lobular cancer, mainly just general questions. So have y'all seen or heard anything at the meeting this year that really advanced our knowledge of lobular cancers?
I have not, but there were a lot of posters and poster discussion sessions that I have not been able to attend or download. So I can't say that for sure. But lobular cancers have gained the interest in research has picked up a little bit. We've known about lobular cancer for many, many years. And we've sort of lumped them in with all the other cancers. Most lobular cancers are hormone receptor positive, about 90% of them are. So we've sort of treated them all in the same way. And a few of them are actually more aggressive and are triple negative, and a few are actually HER2 positive. But they do have one common characteristic. They lack a protein called E-cadherin. And E-cadherin is a very interesting protein that is an adhesion protein. It keeps cells together and creates tight gap junctions, which are a characteristic of epithelial cells. And but they also signal that there's some new data to suggest that they are also signaling proteins. And lobular cancers do not have that. And in fact, that is the definition of a lobular cancer. The pathologist will stain it for E-cadherin, and if it's absent, it's lobular. And in fact, there are rare inherited mutations where people lack the gene that encodes E-cadherin, known as CDH1. And those patients are actually susceptible to lobular cancers, and that's one of the cancers they get. They also get this form of gastric cancer called diffuse gastric cancers. And both lobular and these gastric cancers are very diffuse in the way they grow. They don't grow as a ball. They grow more as like a spider web, if you will. And in fact, they look that way histologically. They cause what are called Indian files. That's what the pathologist will describe them as a bunch of feathers arrayed, infiltrating into the tissue. And they're hard to diagnose. They get missed a lot on mammography. In fact, the more common way for these to be diagnosed is a woman says, my breasts just don't feel right. They're feeling different, especially in certain positions, or a little bit of indentation when I bend over. They get a mammogram, it looks normal. They're sent home. Then they finally come in and finally something is seen, and it may already at that point be advanced stage. So many of them are just not diagnosed. So we need a better way to image them. And even when we know someone has lobular cancer, it's hard to follow it. When people have a recurrence of lobular cancer, the same thing. They're having these vague symptoms, stomach cramps, and and they may even have things that you see on the radiograph, like their ureter is a little distended, but nothing that looks like a mass. And what's going on is it's metastasized and it's growing in a pattern that just isn't discernible. So the first aspect about it, and we actually are starting up a project at MD Anderson for lobular cancers, is to get better imaging technologies for it. And there's a new technology to do PET scanning where rather than using fluorodeoxyglucose, which is a energy substrate that cancer cells use more of, which is why it's taken up by them, using estradiol itself and labeling it with the radioactive material. And that binds to the estrogen receptor. And since most lobular cancers are estrogen receptor positive, for someone that you wouldn't use it for screening, but for someone that already has lobular cancer and you're suspecting a metastasis, this may be a much better way to diagnose it. There's some other PET imaging agents that use PSMA, which is a prostate antigen, but it's also expressed on many other epithelial cells, including breast cancer. So that's another way to look at it. And then there's some interesting information that lobular cancers may be a little more immunogenic. So there may be an opportunity to think about using immune therapy in combination with other drugs that stimulate the immune system. So we're now looking at ways to actually develop specific therapies for lobular cancers, not only in the diagnostic area, but also now in the therapeutic area. But we're not quite there yet. We need to learn more about what makes these lobular cancers tick. There's a couple of people in our department that are working on how E-cadherin transduces signals and how the loss of E-cadherin changes things, and it may be related to the interleukin-8 pathway. And so there's some work going on that may allow us to develop lobular cancer-specific therapies. So there's now a lot of people working on it. The Breast Cancer Research Foundation is funding a group of people to work on it. The NIH now is putting out special requests for applications in this area. So we expect that there's a little more of a groundswell of interest in studying lobular cancers. And there are probably some things at San Antonio that came out that I'm going to find out about later that I can't speak to today. So Doug or Sue, if either of you know, please chime in.
There's a ton of people in the chat commenting on specific posters and sessions. So
great.
I'll have to go back and watch this session again so I can go look those up.
And Christine Desmet is mentioned. She has done a lot of work in lobular cancer and is leading a European consortium. Yes, absolutely.
Yeah, I think the audience is pointing out what a failed job we did as mentors and not getting up at 7 o'clock this morning and seeing the lobular poster discussion session. But that's the bad part about this being virtual. If I were there, I would have dragged myself out of bed and made it to the Stars of Night ballroom or wherever it was. But now I know I can go watch it later. But I will comment, one person brought up the SUMMIT trial, which was really interesting, and it raises a separate question. So the SUMMIT trial is trying to look at HER2 mutation, and it turns out lobular cancers, as I wrote down in my notes, have a higher frequency of HER2 mutation. These were tumors that were not HER2 amplified, and they got nirantinib. And as the trial evolved, they noticed that nirantinib was causing amplification of the mutant allele and added Herceptin and fulvestrant, and they got a pretty impressive response rate. So the question was, and I don't know what the answer is, when do we sequence tumors at what point? So, so now we talked a little bit about the SERDs, the suggestion they may have more activity in mutant ER than fulvestrant. Now we have data that, well, lobulars may have HER2 mutation. They could be targeted with a HER2 tyrosine kinase, fulvestrant, and Herceptin. But we, as clinicians, don't always rebiopsy or even get circulating tumor DNA to do those analyses. So I'm just asking, Debu, what do you do in your practice outside of a research trial? How frequently do you biopsy or sequence patients as they switch therapies?
So we always obtain sequencing at initial diagnosis, especially in hormone receptor positive cancers, because it is now one of the standard treatment options, mostly in second line therapy, is to use PI3 kinase inhibitors in patients who have a mutation in PIK3CA, which is one of the catalytic component of PI3 kinase, and that mutation is present in about 40% of hormone receptor positive cancers. Apart from that, most mutations are not commonly actionable. You mentioned an important one, HER2, and someone also mentioned it in lobular cancers, because we do see it, as you mentioned, in patients, especially patients who have been on endocrine therapy. When you've been on endocrine therapy, you start to select for the small population of cancer cells that may have resistance. And one of the mechanisms of resistance, as I had mentioned earlier, is signaling through the growth factor receptor pathways in general. And one of the growth factor receptor pathways is the HER2 pathway. And you can either signal that way by being a HER2 positive cancer, making an amplified gene in a lot of HER2, or by acquiring a mutation. And these mutations are acquired. They're not generally not present in the primary tumor, or may at a very low frequency, but are present after selection when you're on endocrine therapy. And in lobular cancers, up to 10% of patients who progress on hormonal therapy for hormone receptor positive lobular cancers actually end up having a HER2 mutation. So that's why it's critical to sequence patients not only at the beginning, but maybe at some point later in progression. So now that we have liquid biopsies that allow us to sequence the tumor a little more easily with just a blood test, it may not be as sensitive and as accurate as a tissue biopsy, but it's still, especially when someone is progressing and the amount of tumor DNA is a little higher in the bloodstream, that's a time where we might do a liquid biopsy in someone that has, say, bone only or difficult to biopsy areas of metastasis. So, yeah, I think sequencing is important. And what I hope to see more of, and especially that the price is coming down too, the cost of doing sequencing is becoming less and less. And what I would love to see, you know, Doug, you had alluded to this, is that we develop a way that all the electronic medical records that have this information are able to talk to each other and be analyzed in a centralized fashion. So we could just learn exponentially more about the clinical course of patients that have the different mutations and how that influences their clinical outcome and how they may be accessible for trials. I would envision someday that the electronic medical record tells the doctor, hey, by the way, your patient is eligible for this trial that is open at your own institution or open down the street from you, and on the basis of not only mutations, but other clinical factors. So anyway, I went beyond what you had asked me, but you know, I think genomics is revolutionizing things, and I think we're going to learn more and more about how to drug these many of the mutations that we have. We used to think of some mutations as being undruggable, like the RAS mutation, which is not very common in breast cancer, but very common in lung and pancreatic cancer. And now we have drugs that target the RAS mutation after a lot of investment has been placed by the NIH, by the way, and by the NCI. I think that especially, you know, for patients out there with metastatic cancer, you really should be making sure that your oncologist is talking to you about sequencing and what that may open up in terms of standard therapy and even clinical trials. So, I'm just looking at the, so there are a few more questions on lobular cancers.
Yeah, so there was a question twice. Nancy asked about the difference between local and central pathology.
Well, I can take that one on too. Many trials require that the tissue be sent into a central pathology lab for testing. And when you have a central pathology lab, usually the pathologists that are engaged there are breast-specific pathologists, whereas in a hospital, especially in a smaller hospital, the pathologist may be reading everything from livers and kidneys and skin and breast cancer. And their ability to use the stains and to interpret them may be more limited because they don't do it 100% of the time. And so the general assumption is that it may be a little central read may be a little more accurate. We don't have a gold standard, so there's no true, 100% true answer. But the studies that have been done between central and local reads, especially when there is maybe a gold standard that can be done using more sophisticated assays, do show that the accuracy is a little bit better with the central read. So many studies now require that for a study, if you need to say this protein is expressed, that you have to wait for the central read before you qualify. There's other studies that allow you to go on with the local read, but they still do the central read. And then when the paper's published, they show you the difference. And usually it's off by maybe a few percentage points, not dramatically off. but I'm sure it's quite variable from study to study.
I'll comment. It is critically important, especially if the trial design has a pathological endpoint. So I mentioned I-SPY 2. The pathological endpoint is pathologic complete response. So at the end of therapy, you get biopsied or a specimen is sent to a pathologist, and they have to make that call. Dr. Tripathy's pathologist, Fraser Simmons, is the gold standard for determining whether there's any viable tumor cells left. When we did the I-SPY has roughly 20 sites, and when we asked local pathologists to do this, it was all over the map. The confidence intervals were huge. There was a lack of confidence intervals were huge. So what Dr. Simmons did was he went and trained everybody, got all the pathologists to sit down and say, here's how I call past CRs. You see this thing here, that's a dead, dying lymphocyte. That's not viable cancer, but this one is. And then he sent around the slides to all the pathologists to get them to review it. And even then, it wasn't perfect. So I do think having somebody who really knows what they're looking at is critical to outcomes, particularly if, and we made this mistake around HER2, even calling HER2 by immunohistochemistry was fraught with all sorts of issues when that first came out. So central pathology hopefully is the gold standard, but your pathologist had to be trained and interested in doing the right do the right reading.
So we've been talking this entire time pretty much about drug therapies. So I want to pull Dr. Love back in here and I want to ask you, where does surgery figure into all of this? I know that I've heard you say in the past that maybe we'll rely less on surgery.
Yeah, well, I think too the lobules particularly are dispersed. They're like leaves on a tree, and so if each lobule has cancer in it, you still may not be able to get the whole tree. You need to get all the leaves out. And I'm thinking of it, looking at your background. You have all these leaves on the tree on your background right now. But so lobular is not a good surgical. We don't like it because it doesn't make a lump. You can't feel it. It doesn't really show up extensively on the mammogram. And so it's tricky, and it's much more likely you're much more likely not to get good margins around it. And so if there was a way that you could treat it by drugs and radiation and skip the surgery, I think you'd have a lot of happy surgeons. And patients too, probably.
There is a question about liquid biopsy. And how do we use that? So I think we've heard some very interesting and intriguing uses of liquid biopsy to look at circulating tumor DNA or cell-free DNA. But I will say at the moment, so it's always the fact that you can do it doesn't always mean you should do it. And in the clinical setting of patients with the two clinical settings that have come up that I think are fascinating research questions that we need to address. One is patients who have operable breast cancer, and then they're followed. And then if you follow with blood and you determine that there's presence of circulating tumor DNA, is what do you do about that? And then the same thing is also true in metastatic breast cancer. If you start to see an emerging clone arrive, and there was a very nice presentation, I can't remember what day it was, on estrogen receptor mutation, should you switch therapies because you see that? So I would argue as of today, these are research questions that they're not quite ready to use for clinical practice because we don't have the data that either switching or acting on the information is the right thing to do. But I'm happy to have other people offer a different opinion about cell-free DNA and the particular question asked about BioSep. It's hard to know what to do with the information, and that's the biggest challenge.
Rod has asked a question here a couple of times, actually. He wanted to know, since neoadjuvant chemo gives you the answer to initial chemo efficacies, do you think this is best for beginning early stage breast cancer treatment? I know we're the feedback again. And
2% of patients with the
metastasis. So, as a medical oncologist, and Susan, you can tell me this as a surgeon, I always tell my surgeon that if we all think the patient needs chemotherapy, let's give the chemotherapy before. So I think most people's practices have evolved to almost everybody with a reasonable size HER2-positive breast cancer should get neoadjuvant therapy before. And one reason to do that is to make Susan's job easier. You know, I also think doing neoadjuvant therapy gives patients a long time to think about what surgery do they really want. They can interview reconstructive surgeons. They can get their genomic germline testing back, and can make the right decision. It's not like, and I know Susan doesn't do this, but it's not like, I got to scrub out of my schedule next week, I'll do your bilateral mastectomy then. That's not the right answer. So neoadjuvant gives you a little bit of cushion. But beyond that, if patients do not have the response you want, especially in the world of HER2 and now triple negative, there are things you can do in the adjuvant setting. You know, we heard this story for germline mutations around olaparib. We got some updates on the Xeloda, the capecitabine studies, and certainly TDM1. And I will bet you any amount of money the TDXD will be better than TDM1 in that setting. So a HER2-positive patient who has a residual tumor will get TDXD versus TDM1. TDXD will almost certainly be better if I were a betting person. So at any rate, I think in the situations where somebody needs chemotherapy, I don't think there's a huge downside to giving it before surgery. Having said that, if that argument about lymphedema and getting neoadjuvant chemotherapy was associated with more lymphedema, I'd have to think twice about that in some situations. But for the most part, that's not so much of an issue.
I agree with you. I think also the advantage that of being able to see the tumor shrink, and so you know that you're getting at least some benefit from it, or not, is very worthwhile. So that if you operate and then do the drugs, you don't get that immediate reaction or ability to tell that. So I think that's better. The surgery is easier. It's not like it's one of the things we've learned in my career is that more is certainly not better in terms of breast cancer, surgery, and it's not really curing probably most people. I started out when we were fighting radical mastectomy versus lumpectomy and radiation, and there was no difference there. So I think that things have changed a lot, and surgery has become the sort of cleanup after everything else, if absolutely necessary. And most of the time, it's not.
So we did have a question, a surgery question again for you, Dr. Love, to comment on the use of surgery in advanced breast cancer. So can reducing the tumor burden have positive effects? What are your thoughts on that?
Well, when I started, we always did the surgery in advance. We did that first until we realized that you really could use the surgery or use the reaction to the drugs to give you a chance to know how much surgery you had to do. Because in the early days, we were doing mastectomies and, even radical mastectomies when I started. So realizing that what you do in the breast is not the key thing, and it's not going to be. It's not if you do more surgery, you're more likely to live than if you do less surgery. It has much more to do with trying to reduce the bulk of the tumor and then using something else, the chemo and the radiation, to clean up. But I think surgery has used to be the key thing, and now it's probably, we use it when we need it, kind of idea. So it's a good thing that I'm retiring, and don't have to depend on it. But it has taught us a lot about breast cancer over the years, and it's good that we don't have to do as much surgery.
With early stage ILC showing similar.
Great, thank you. So while you were away, Dr. Tripathy, of course, questions came in for you. Um, so they want you to comment on liquid biopsies.
Well, liquid biopsy is a general term that applies for information you can get from a tumor through the blood. And ever since the days of Rudolf Virchow, a pathologist who was probably the person who was able to visualize tumor cells in the bloodstream, there's been an interest in this. The initial version of it was actual cells that you could see circulating in the blood. And they're so rare compared to white cells that you had to develop enrichment techniques using, for example, an antibody that recognizes proteins expressed only on the surface of tumor cells or epithelial cells, and then labeling them and separating them out and looking at them. And by doing that technology that was developed, about 10 or 20 years ago, we were able to see that circulating tumor cells can be identified. And in breast cancer and now in other cancers, it's been shown to be the more circulating tumor cells you have, the worse the prognosis is. But you can also get a lot of information about the circulating tumor cells in terms of what proteins and genes are seen there. And now we can actually analyze these tumor cells and be able to understand what mutations are seen. And they may not always be the same complement as to what you see in the tissue. More recently, we have now been able to just look at DNA that is circulating in the plasma. So we're not really looking at circulating tumor cells, but this is a little easier. You now don't have to enrich for these cells, and you can just separate out the plasma and look for DNA that's of a certain size that corresponds to the tumor DNA, and you can analyze it and sequence it. And in fact, now, if you know the sequence of the original tumor, you can do very sensitive assays that can look for recurrences in patients with early stage breast cancer, because it gives you an early window into whether or not someone is recurring. But these tests are not fully accurate, and we don't know what to do with that information yet. So as this technology develops, we want to make sure it's developed in a responsible way and that we use this information to help patients. But what it is used for today, though, is a way to understand the tumor mutational profile by a simple blood biopsy. And these assays are now commercially available. And like I said, they're pretty accurate, maybe not as accurate as a tumor biopsy. But we're also learning a lot about biology by doing serial blood monitoring in patients that are on therapy, because what we're starting to see is that the mutational profile of a tumor changes over time. For example, when patients are exposed to hormonal therapy that lowers estrogen levels, a so-called estrogen deprivation therapy, like aromatase inhibitors, we see that over time, tumor cells or the DNA of the tumor cells starts to acquire a mutation in the estrogen receptor that I mentioned earlier, ESR1 mutations. And the reason we see these emerge is that they're subclonal. And when I say subclonal, what I'm talking about is the fact that a tumor mass or tumor cells are not all identical. They're not all carbon copies of each other. There's some diversity in the tumor cells, so that there may be a very small fraction of the tumor cells that actually carry a different mutation than the rest of the tumor cells do. And if that particular mutation happens to give that cell a growth advantage, especially against a drug that the patient is on, over time, that subclone is going to continue to grow while the other ones don't, and it overtakes the tumor, and then the tumor switches from having normal ESR genes to having these mutant genes. And by looking at which genes change over time, we're learning about what drives resistance to that drug in a situation that we may not have known. And by doing that, we discover genes that drive resistance and then how to develop drugs against the protein encoded by that gene. So nowadays, it is standard when you are running a biological drug clinical trial to get serial blood and bank them, and later on do the sequencing. In fact, if you're doing a biological drug trial, whether it's a phase 1 or a phase 2 or a phase 3 trial, and you're not collecting blood, someone will look at you like, you've omitted something, which you have, because we're learning a lot through serial liquid biopsies. Now, what's lagging far behind is how we apply this in clinical practice. So we are applying it in clinical practice now for sequencing DNA and to help assign patients to either clinical trials or approved drugs that map to certain mutations. But we're not yet necessarily using it for diagnosis of recurrence yet. And that is because we still don't know exactly what to do. We don't want to get into a situation where we're telling patients, oh, we can pick up the tumor DNA in your blood now, even though you had early stage breast cancer and we were hoping you're cured. But you don't have a treatment or you don't have a protocol to put them on. So we have to make sure that as we evolve this technology, that we develop very reasonable trials that are going to help us or that are going to allow us to give a treatment to someone. The other thing that we can use this technology for is not to have to wait for 6 months or a year to see if a drug works. We can actually find out in 2 weeks if someone is likely to respond to a new drug. And it allows us to personalize therapy and to accelerate drug approval or drug discovery. The other thing that I've always thought we should be doing is a trial where we expose someone to a drug for a brief period of time and then maybe expose them to another. And the one that gives you the largest drop in ctDNA is the one you stay on. So if you have one that doesn't quite drop it enough, let's move on to the next option. And this way, patients aren't seeing progression on their scan after the tumor has increased in its tumor bulk by 100%, which is about what it is when you see a change on the scan. So we would be able to adapt therapy much more earlier, especially when someone has many options. So there's a myriad of things we can do now with this new technology, from discovery to application in patient care. And I think you're going to see many of these very innovative trials start to come up. And it may allow us to actually discover whether a drug works or not in a much faster period of time with smaller number of patients. So I think the potential fruits from this are quite high, quite large, and we just need to develop in a responsible and ethical way.
Where do you see cancer treatment going in the future? So each of you will get 2 minutes, and then I'll do 1 minute for close, and we'll end on time. How about that?
Doug?
So one of the things that I think we will see more and more of are the antibody drug conjugates. We as a research community have spent a really long time characterizing what's on the surface of cells. And obviously HER2 is the best case of example of something that worked really well. But now that we know, and this came up at the end of the year session for metastatic disease, if some drugs like TDXD work in HER2 low, it's nothing to do with HER2's biological function. It's just that it's there as a marker. So now that we know this works, and drug companies have gotten the antibody, the linker, the payload parts down, I'm very enthusiastic about this. I want to see somebody come up with either a good antibody drug conjugate that really works well in luminal B estrogen receptor breast cancers, particularly used in both the metastatic and the adjuvant setting. And I think it will come probably within the next year or so.
All right, next up.
Data was collected. Control trials.
I think it's so interesting to me that we've gone from we went from radical mastectomy to modified radical to lumpectomy and radiation, and now we're sort of going back to modified radical and surgery. And I hope that we have a new way of looking at the milk ducts and where they are, and they're not in quadrants at all. There's an inner group and an outer group, and if we can easily identify what duct has, say, DCIS or the early changes or atypical hyperplasia, you could do a liquid biopsy, make that diagnosis, squirt the treatment down the duct, be done. And Debu will laugh because I've been saying this for years. But we're getting there.
This figure shows time to any recurrence by central
and I think breast won't be a surgical problem anymore. So that's where I think we're going.
Age, nodal status, and
I will just be very brief, because I think we're moving towards more personalized therapy, and whether we're personalizing it on someone's genomic status or their inherited genes, or whether we're personalizing it on their preferences and how they see their quality of life versus benefits. We've seen a lot of personalized drugs come out that are based on someone's unique gene sequence, but we're also seeing trials where patients can weigh in on the side effects, and we can monitor their activities, and we can help them identify which is the best path for them, especially when it comes to things like cancer prevention for people that carry inherited abnormalities, when it comes to cancer screening, and when it comes to diagnostic imaging too, as we spoke about earlier. So I think that's a welcome trend for people to find their own path, but also to find the best path for them.
Okay, so since our mentors are all a captive audience here, I'll just make a statement real quick. We don't have time to talk about it, unfortunately, but I know that in our previous 2 Hot Topic sessions, we've touched on the fact that personalized medicine sounds absolutely fabulous, but what is the cost going to be? And what about access to care? Most patients are treated in the community setting. You know, it's harder for people in rural communities to access this. How are we going to get these latest and greatest out to the rest of our country? And, you know, listening to Dr. Olapade, she really emphasized getting this out to the rest of the world. So on that note, I guess we will conclude. But I wanted to thank you all for a wonderful session and a great discussion. There are questions in the chat, which you guys may want to read through at your leisure, you know, so you can know what's on the mind of the patient community. I really want to give a special thanks to our mentors, Dr. Love, Dr. Yee, and Dr. Tripathy. We're just so grateful for you sharing your Friday night with us. I'd also like to thank our sponsors, without whom this program would not have been possible. Exact Sciences, GE, Genentech, Pfizer, Seagen, Merck, Agendia, Sanofi Genzyme, Eisai, Viatris, Grail, Daiichi Sankyo, Sino Medical, and Cyber Media Productions, who has been responsible for tonight's broadcast, as well as our 2 previous broadcasts and our other educational offerings from ABCF. So this is our last advocacy event for the 2021 San Antonio Breast Cancer Symposium. I know we had some questions earlier in the chat about how you can watch these programs. They are going to be available on this Socio platform for a while. Not just the Hot Topics, but there are you know, the advocate chats and some of the FDA programs, ACR special programs that are here that originally aired under on the Socio platform. So those will be available for you to access. They will eventually be uploaded to the ABCF website, and there's a YouTube channel for ABCF where you should be able to see them. So I hope to see you all in San Antonio for next year's meeting. It's going to be December 6th through 10th of 2022. And on that note, we ended on time. Thank you all so much, and happy holidays.